Good afternoon. This is Kathy Neckham, the Education Director for the DPC Ed Center. I'd like to welcome all of you to our June webinar on bone mineral disorder. Thank you all for joining us. We will be recording this session, and we will have slides and the recording information to you in about a week, if not sooner. We also, you will notice there's a chat box, and you will be able to put your questions in the chat box to us, and we will answer those at the end of the presentation. So any questions that you have during a certain part, you're welcome to put it in there, and we'll go back and get to it at the end of the session. If for some reason we wouldn't get to all the questions, we will get answers to them and send them out to you. I'm excited today to be able to introduce our speaker, Frances Rodriguez. Frances is a registered dietitian. She's been a dietitian for over 6 years. She's also a board-certified specialist in renal dietitian, which sort of was a new thing for me to learn more about. And she has over 4 years of experience in dialysis. She also works with people who have CKD. She also likes to present and educate healthcare professionals, and is a 2-time presenter at the annual symposium for technicians at the National Association of Nephrology Technicians, which has been in Las Vegas, Nevada. She's also an advocate for patient access to dialysis in California when she lived there. She's currently living in Texas. And at this point, Frances, I'd like to turn the program over to you so you can talk about the objectives and help us all learn more about bone mineral disease.
Awesome. Thank you. Thank you for that introduction. Hi, everybody. Thank you for joining us. So as Kathy said, let's move on with the objectives of this presentation. So we are going to start by learning the relationship between our kidneys and our bones. A lot of people, they can put one and one together, right? And then we're going to deep dive into what is renal bone mineral disease. And we are also going to review how our diet impacts renal bone mineral disorders, what foods we should avoid, and what changes we can make on our diet to slow down the progression of this disorder. So as a quick introduction, CKD, or chronic kidney disease, it affects approximately 15% of the population in the United States. This looks at 1 in 7 American adults in the United States. They have CKD. Most of them, they don't know it because the first stages are considered silent. And the main 2 causes or leading causes for this condition are uncontrolled diabetes and or hypertension. There is a small population of people with kidney disease that they have a genetic component. Their parents had kidney disease, they have a congenital disease, so not necessarily you need to have diabetes and hypertension to develop chronic kidney disease. And to define what it is, it's a kidney damage that occurs or happens for more than 3 months. We have acute kidney injury, which usually resolves quite quickly, but when this damage lasts more than 3 months, then this is what we consider chronic kidney disease. And simply it's a reduction in the function of the kidney. There can be structural changes or functional changes in the kidneys, and the doctor uses what we call the GFR, the glomerular filtration rate, to classify the stage of this condition. So we have stage 1, stage 2, 3, 4, 5, what is considered end-stage renal disease, and 5D, what is considered people who are on dialysis. So to review pretty quick the functions of the kidney, I think it's very important for us to know what are the functions of the kidney, because most people, they think about the kidneys as this organ that produces urine and, removes the fluid out of the body. However, the function of the kidneys are more than just, going to the bathroom and peeing, and producing urine. So the first function is excretion. So the kidneys helps to filtrate the blood and remove that excess of fluid, the water, the fluid that we drink, but also help us to remove any waste products like vitamins, minerals, urea. The kidney also help us to keep the acid balance of the blood, right? So the blood has a pH, our urine has a pH, and the kidney, in addition to the lungs, it helps us to keep this pH within range, and this is the reason why we don't have to drink alkaline water or eat alkaline foods, because the kidney and the lungs do this function. And then the last function, which is the one that we are going to be talking about today, it will be the endocrine hormone production. So one of the hormones that produces is calcitriol, which is an active form of vitamin D. And we need to keep in mind these because, as I said, this is what we're going to talk about for the rest of the presentation. And this vitamin D, it helps with the absorption of calcium in the system. The kidney also helps to produce erythropoietin, and this is a hormone that helps us to increase the production of red blood cells. And it's the reason why people with CKD, they tend to have anemia, and it's because the production of this hormone gets impaired and decreases with this condition. But that's not the topic for this presentation, but it's good information to know. So the hormonal function, endocrine function of the kidney, I want you to think about it as a feedback method, right? The kidneys and the PTH and the bone, they all communicate, right? And based on where our calcium and vitamin D levels are, it's going to be how they're going to behave. If they're going to activate, if they're going to shut down. So it's like a feedback method based on the calcium and phosphorus levels of the blood. So we have, as I mentioned, to keep in mind that the activation of vitamin D, it happens in the kidney, right? And we need this active form of vitamin D to absorb the calcium that we eat. So when we drink milk, when we eat yogurt, the calcium that is present in these foods are going to be absorbed by, it's going to be absorbed by the gut with the help of vitamin D. So in the normal state, whenever there is a small change in the amount of calcium in the blood, it stimulates a hormone called parathyroid hormone. You're going to hear a lot about it, from your doctor, your dietitian. We call it PTH. This hormone, it gets produced by 4 glands behind our thyroid, right? So whenever there is a small change in the concentration in our blood, these glands kind of like feel it, and if he feels that it's too low, it goes to the bone and releases calcium out of the bone to restore the balance. And this is the feedback method I was talking about. This hormone also helps to activate this vitamin D, so the absorption of calcium in the intestines can happen. And this hormone is also going to help with the absorption of phosphorus and increases the excretion of these minerals when there is too much in our blood. And again, I'm here talking about the normal state because this changes when the person has kidney disease. So let's start with renal bone mineral disease. It usually starts around stage 2. And as I said, CKD can be a silent disease. Most people don't notice it until they present symptoms closer to stage 3, 4, sometimes even 5. So we're talking about that these changes start very, very early in the disease. So when the function of the kidney goes down, there is a decrease in the activation of these vitamin D in the kidney because not that much of vitamin D is present, calcium doesn't get absorbed, and then PTH, increases trying to kind of like activate more vitamin D. PTH is also, calling the bone like, hey, I need calcium, and it releases calcium out of the bone. And something important to keep in mind in this stage is that if we were to analyze your blood work, you go to the lab, you get your blood work done, and we read your labs, most likely your calcium and phosphorus levels will be within range, so these won't be noticeable in the lab. This is a representation for those of you who are more visual and prefer, diagrams over words. So again, we have everything starts. Let me activate the pointer. Everything starts with the kidney, when the kidney function declines. Again, that function declines, the activation of that vitamin D declines, the absorption of the calcium in the gut declines as well. And while these two are happening, PTH levels are increasing because PTH thinks there's something wrong with her. I call it her, it's a she for me. So PTH starts producing, so vitamin D can get activated, calcium can get better absorbed, we retain phosphorus in the system as well. So this is how this system all works together. And again, it's a feedback method. If we have good activation of vitamin D, calcium is within range, PTH level goes back to normal, and we don't have to retain that much phosphorus in our system, right? So moving forward, then we are looking closer to the stage 3 of this disease. Here we definitely are gonna see even lower levels of vitamin D in the system, and PTH are gonna be slightly higher than the usual or the normal range. With time, the parathyroid glands are going to keep overproducing PTH to the point that they can overgrow. And with time, in the long term, we call this secondary hyperthyroidism. It's an overproduction of this hormone. And with time, because this hormone, PTH, is not able to activate the vitamin D, it's not able to absorb the calcium from in the intestines, PTH keeps getting calcium out of the bone, right? And it keeps subtracting calcium out of the bone. And with time, these leads to a loss of bone density and mineral loss in the bone, right? So picture it as a building. It's a building that you're pulling bricks one on one. With time, what's going to happen? That building is not going to have that structure. It's not going to be as strong. It's going to be hollow. So these can lead to micro and macro fractures in the long run. And it's why this is so important. In the long run, long-term implications, usually we see these implications or consequences, I will say maybe 10, 15 years after, that first initial stage, when these changes are happening. We're going to have calciphylaxis, and it's that picture that you see in the top right. Calciphylaxis are very painful skin lesions that happen. And you can see an accumulation of calcium. It's a very painful. Usually we see this in patients that have been in dialysis for quite some time. And it's usually treated with a medication that it's given IV, usually given at the dialysis center until this lesion, it heals up. We also are going to be seeing vascular and soft tissue calcification. As I say, we have all this calcium floating in our blood because the body thinks there's something wrong, right? And with time, this calcium in our blood, it leads to calcifications of soft tissue. So we can see this calcification in our eyes, heart, blood vessels. And with time, this is going to increase our risk for morbidity and mortality. So when I was working, with dialysis patients, it's something that I used to emphasize a lot. Like, you might not feel any symptoms right now. You might feel fine. You might not be in pain. However, by the time that you realize all these changes and you notice it, maybe you have this type of wound, or you go to the doctor and they tell you, you have fractures in your bones, it is too late to do anything, okay? And it's the reason why we have to take action before all these complications happen. So what causes bone mineral disorder? As I already said, it all starts with this abnormal metabolism of calcium and phosphorus, the vitamin D deficiency, and the secondary hypothyroidism, which is this overproduction of PTH. There are 3 different types of renal bone disease. I'm just educating you about it in terms of the treatment and what you can do. There's not much. I think this is more applicable for the physician, because based on the type of renal bone disease, it's going to be the treatment that the nephrology is going to choose for you. However, in terms of the patient and what can I do with the diet and taking my medication, it's going to be the same, okay? So this is just a little bit of information so you know. We have a high turnover type of renal bone disease, and here it is caused by this secondary hypothyroidism. We usually see it on patients that have a very high PTH level. So you have a reference. In normal range of PTH, we're looking at between 20 to 90. For patients in dialysis, we aim to keep those levels between 150 to 300. Other doctors say aim 150 to 600. The high levels that I'm talking about here, I'm talking about the thousands, 1,000, 2,000, 4,000. I even have patients at the 4,000s, right? So here, what it's going on, it's like the calcium, the PTH is pulling calcium so quick and so fast out of your bone that it doesn't give enough time for the bone to regenerate and form again, right? So it's a rapid turnover. And if you see the factors that lead to this excessive PTH secretion, we can have, of course, the altered vitamin D metabolism, the hypocalcemia, which is the low calcium serum levels in the low calcium levels in the blood, and the phosphorus retention, and that's why it has to start, because it's kind of like the purpose of this presentation. So with time, as I was saying, the body produces a lot of PTH, but by some reason, the body becomes resistant to that PTH. So we have this double problem. It is producing more PTH, but at the same time, the body is not as receptive, so it keeps producing PTH, over time. Then the next one is what we call mixed uremic bone disease. And it's mixed because we can see a combination of the high and the low turnover. Again, nothing that changes how you, as a patient, what you're going to do with your diet, just a little bit of awareness. However, this one, we can see it in patients that they have taken maybe aluminum for too long, aluminum binders for too long. High phosphorus can lead to these as well. But again, for you as a patient, it's having control of your diet. Then the last one, it's called low turnover. It's completely the opposite. The rate is super slow, so there is a lot of pulling of calcium out of the bone. However, the formation of the bone is not as quick as in the first one that we spoke about, right? It's commonly caused by the oversuppression of PTH. There are medications that help to suppress the PTH action. These ones are going to be prescribed by your nephrologist, right? However, if the patient is not being monitored, if the body is too sensitive to these medications, PTH level can go down and cause a dynamic bone disease. However, this happens with time as well. It's a long-term effect. So most likely your doctor is going to be monitoring your PTH levels, phosphorus, vitamin D, calcium, and so on. So what can I do as a patient to prevent, bone mineral disorder? I will say that unfortunately, if you have already CKD, there's not much that you can do to prevent. I will say that sooner or later it's gonna happen. Definitely, how much you control your phosphorus levels, it's gonna be the long-term complications, the calcifications, the problem with the heart, the faster decline in renal function, right? So this is why it's so important to control phosphorus, and why you hear your dietitian and your doctor, hey, your phosphorus is high, hey, you have to stop eating these foods, hey, you have to take your medication, hey, this is important, and it's like a continuous preach, right? If you're in dialysis, it's month after month, the phosphorus talk, okay? And this is the reason why, because it's so important. Hyperphosphatemia, or high phosphorus levels in the blood, is the greatest risk factor for renal bone disorder. And for every 1 milligram increase in phosphorus, we aim for something, the range is between 3.5 to 5.5. Each milligram above that range, it's going to be an increase of 10 to 62% in mortality risk, okay? So keeping that phosphorus level, it's going to be extremely important. If you are a patient that you're not in dialysis, you are stage 2, stage 3, stage 4, the higher the phosphorus levels you have in your blood, faster it's going to be your decline in kidney function, which means that you might need to start dialysis sooner, okay? So again, even if you don't feel it, it is extremely important to control your phosphorus intake. And why is so important, right? We have high phosphorus levels, but we also measure a product. So we calculate how much calcium is in your blood, how much phosphorus is in your blood, and they give us a number. The higher that number, the higher this product, higher is your risk for calcification, and higher is your risk for mortality. It has been associated with a high dose of calcium-containing binders, and I'm not saying that calcium binders are bad, but if you need a high dose of calcium-containing binders to control your phosphorus levels, these can lead to calcifications later on. So let's talk about the phosphorus control, right? This is going to be me as a patient. What can I do? Like, this is your time to show and, show your doctor that you are really, really invested and you really want to work on your health, right? What is the thing that you can control? It's going to be your phosphorus intake. And the reason why, it's because the higher the phosphorus, as I said, higher PTH, higher mortality risk, and all these complications that we just reviewed. So this is a two-part thing. It's going to be what you put in your mouth, your dietary management. So the phosphorus that you eat from your food, but it's also going to be the phosphorus binders. So The main goal as a dietitian, as a renal dietitian for me, is to work with my patients in a way that we can develop a diet plan that eliminates phosphorus that are very high in phosphorus without compromising the protein needs, okay? For patients that are on dialysis, they know that they need to eat more protein. However, all proteins contain phosphorus. So we're gonna focus on maybe avoiding foods that provide a lot of phosphorus, but maybe they don't give us as much protein, right? So with phosphorus, we need to talk about how much we absorb, because not all phosphorus is absorbed the same way. We have two different types of phosphorus. We have the organic one, and what I'm talking about organic is organic. It's natural. No one added this phosphorus to the food. So I'm going to give you some examples so you know what I'm talking about. Oatmeal, corn, milk, yogurt, eggs. No one adds that phosphorus to those foods, right? The absorption of organic phosphorus, it ranges from 40 to 60. If it is phosphorus from plants, so for example, oatmeal and whole grains, it's going to be lower. It's going to be less than 50%. So we need to eat more of these foods, right? Because the body is not going to absorb as much. On the other side, we have inorganic phosphorus. Inorganic means not natural. You can look at it as additives and preservatives that are added to the food to make it taste better, look better, retain moist, shelf life, right? So these additives are extremely absorbable by the body, right? I'm talking about like 90% of the phosphorus or these additives are absorbed by the body, okay? And most of the time, these foods are not as healthy. So what am I talking about? I'm talking about hot dogs, I'm talking about dark sodas, pastries, donuts, cake, right? A lot of additives are added to those foods. So kind of like keep in mind how healthy and how much, you know, that food, how much nutrition that food has versus how much phosphorus you are absorbing from that food. And something to keep in mind, the cooking method that you use is going to affect that availability, that absorption. So for example, if you are going to cook a meat, it's better if you either boil it, you steam it, you bake it versus if you fry it or you grill it, okay? So this is something to talk about with your dietitian when you develop a plan, right? And see what foods you eat and how to cook them in a way that they don't promote a high phosphorus absorption. I will say that with phosphorus, it is one of the most complicated themes of this diet. And the reason why it's because phosphorus content in food, it's not mandatory to be disclosed. So, you know, when you look at the nutritional label and it says sodium, now potassium is included, carbs, fat, calcium, vitamin C, phosphorus is not mandatory to be disclosed. So you don't know how much food. We don't know how much phosphorus most of the foods that we eat have, right? So what can we do? We can look at the ingredient list, right? How we have here in this picture. We're going to look at the ingredient list. And if you see the arrows, right, we see aluminum phosphate and monocalcium phosphate. That tells you that this product contains phosphorus additives. So if you look to the list that I have on the left side, phosphoric acid, that can you hear it? The phosphoric acid, it's the one that is present in dark soda. So something like Coca-Cola, Pepsi, Dr. Pepper. something to keep in mind, this one is not present in most clear sodas, and that's why usually drinking clear sodas is a little bit better. Sodium phosphate, calcium phosphate, monosodium phosphate, all of those are phosphorus additives. This list, it's way longer than this. I just wanted to give the example. And again, look at that part of the word that is in red. That's where you're going to look for when you look at the ingredient list. And something to keep in mind, the closer that ingredient or any ingredient is to the top of the ingredient list, more it has, closer to the bottom of the list, least of that ingredient has, okay? So this ingredient list on the back of that food item, it's gonna give you the information that you need. So look at everything that you have in your house. When you go grocery shopping, look at that and choose items that do not contain phosphate additives. Here I have the My Plate graphic because I feel like one of the hardest things for people to kind of like realize is like there are a lot of foods that you can eat, right? We kind of like just think about the ones that the dietitian told us not to, right? So with My Plate is a method that we use to teach our patients how to eat, and I use this method with people who have diabetes, people who want to lose weight, people who just want to eat healthy. We just have to follow this visual. So here, as you see, half that plate is fruits and vegetables. Depending on your potassium levels, the fruits and vegetables that you can eat, and that's a discussion that you're going to have with your doctor and or dietitian based on your numbers. But half of that plate is going to be fruits and vegetables, right? Make sure that they are fresh, you don't add a lot of dressing, they are not breaded, fried, because it kind of like defeats the purpose. On the other side, we have the grain, right? And we're looking here at pasta, bread, rice, oatmeal, grits. And then we're gonna have the proteins. And the protein, how much protein you need, it's gonna be depending on the stage of CKD that you're at. So usually when people are stage 3, 4, even 5, some doctors, they recommend to, avoid eating excessive amount of protein. However, when you start dialysis, you need way more protein because protein, it gets filtrated through the dialysis, so we need to replenish those needs. So this is just an example for you to know how to build a healthy plate. Again, talk about it with your dietitian and your doctor based on your numbers. It's gonna be how much of protein you're gonna eat and what fruits and vegetables you are going to be consuming. And then we have the phosphorus binders. This is a medication that your doctor might prescribe if your phosphorus levels, they go too high or above that number, right? With this, the doctor is just trying to keep that number within that range. So all those complications that we already reviewed, they don't start affecting you. So the important part about the binders, they have to be taken with your meal. Every single meal we have to take the binders, okay? This medication, it works by, it kind of like binds, it kind of like links to the phosphorus that we eat in our food, and that way it decreases the absorption. It is very important to remember and to keep in mind, as I said, you have to take it with every meal. It is usually recommended between maybe 15 minutes before you start your meal to, I will say, maybe 30 to 45 minutes after you are done eating. I will say within that window, right? If you are forgetful, and let's say you had breakfast and 2 hours later you remember that you forgot your binder, the reality is that if you take the pill at that time, it's not going to work as much because that digestion and absorption of that food. It's already happening. So by the time that, the binder makes it to the stomach, it's going to be too late. So I will say develop a habit to remember to take your medication with all your meals, right? Some people, they keep it at the table. Other people, they keep it in the nightstand. Some people, they put an alarm on their phone. Other people, they take it on their first bite, third bite, right after they're done eating. Whatever works for you, just please make sure that you take this medication with the food, especially if you're eating something that is high phosphorus. I don't know if you remember that I said that the PTH, goes to the bone and pulls calcium out of the bone. Unfortunately, when this calcium comes out of the bone, phosphorus gets released out of the bone as well, right? And if your PTH is too high and you're still taking your binders and you are following the diet, most likely this phosphorus, it's coming from the bone, not necessarily from the diet, and this medication doesn't help from that. It doesn't help in this instance. So if the phosphorus is coming from your bone, it's not going through your stomach, so the pills is not going to work in this, with the absorption of this phosphorus. As a small review, I don't want to get too much into detail because I'm not a doctor. I am not a pharmacist either. In the market, there are different types of binders. We have calcium-based, we have synthetic or resin-based, and the newer ones are iron-based. So it doesn't matter which one your doctor prescribes for you. Please make sure that you take it with all your meals. Keep it on you at all times. Buy a pill box so whenever you eat out, you have them on you. Because they definitely, if you take this medication as prescribed, it definitely is going to help you with your phosphorus control. And lastly, with the vitamin D deficiency is extremely common, and it's highly common in patients with kidney disease. So as we saw earlier, there is a decline in the activation of the vitamin D, and it's what causes, the calcium levels to go below the range. So some doctors, they can prescribe vitamin D, the one that you buy at the pharmacy. However, I will recommend that you talk with your doctor before doing so. And I think this is it. I think we do have enough time for questions. So I think that's pretty much for me. Kathy, if you want to read questions, or if someone has a comment or maybe something that I have to clarify, I'm here to address those.
Okay, thank you so much, Frances. I was taking notes and I started having a question, and after I wrote my question, it's like you answered it. And so you certainly gave us lots of information. I welcome anyone to put a question in the chat box. So we'll wait a little bit. We don't have any in there right now. We'll wait and see if anybody has any. Frances, I really liked the images that you did throughout, like the building and taking out the bricks. And a couple of times I'm going, oh, that's a great way to remember things. So,
yes, renal nutrition is extremely complex, right? So as a dietitian, part of my duty and purpose is to grab all this scientific information and turn it into simple words that the patient can understand, right? Not everybody is able to understand, medical concepts. Maybe as a doctor, we'll talk to you. Sometimes, I have patients that the doctor, they told them something, and they were like, huh? Like, what did he say? So as a dietitian, it's, it's my job to kind of like, okay, this is what your doctor meant. This is how you do it, right? So that's kind of like what we do at the clinic. And as a dietitian, I'm an educator, so that's what I do.
You did from my perspective, you did a great job.
Thank
we do
you.
have a couple of questions here. So Rose has a question: what tools can patients use to help with phosphorus control?
Okay, so I'm not quite sure what type of tools maybe she's talking about. I will say, again, the binder and making sure that you don't overeat processed foods. I often saw that the patients that they were more into cooking from scratch, cooking more like healthy meals. They didn't rely on processed, frozen, ready to prepare, kind of meals. Those patients, they tend to have way more better control of the phosphorus than the patient that was like always eating out, stopping, at the fast food on their way to dialysis, or patients that they will rely on TV dinners, or you always saw them, eating a donut or a pastry. So I will say that it will be a good way. There are some apps out there that they might help you with the phosphorus, kind of like to keep track of your phosphorus intake. But I have never tried them, to be completely honest, so I don't know how accurate they might be. But I would say if you avoid these type of food, that should help with the phosphorus control. And Rose, if I'm not answering your question, please let me know exactly what tools we're talking about so I can point you in the right direction.
Okay, thank you. What about potassium levels on bones?
That is not usually a concern. I'm not sure in what terms she's talking about, but potassium is mostly in the muscle. It's also in the blood, so not so much in the bone. If a patient has, and I don't know if Jessie is a patient or maybe a provider, but in terms of potassium, a lot of it has to do with dietary. Potassium is very, very, very related to the diet. So, okay, so you're a patient. In that sense, it'll be more what you eat than anything that comes out of the bone. I don't think there is that much release. Potassium is mostly found in muscle. So I don't think there will be that much relationship. Again, it's more what you eat. And I hope that I addressed that question. And if not, we have plenty of time. You can keep typing your questions, Jessie, okay? Then I see the question about bone mineral density scans. That is one of the tools that we can use. However, it's a procedure that the patient can have, and it needs to be, go to the place to get these tests done. It will help you to see how the density of the bone looks like, but in terms of the treatment, I'm not sure how the doctor uses this information. As a dietitian, I never use that. I don't use it. I don't look at it. I usually, focus on how the patient feels, what the patient is eating, and the numbers of the lab work.
Okay, are there any other questions? Like you've gone through them?
Yeah, I'm not sure if I addressed the question that Rose had. I'm not sure if I was able to provide the information that she needed.
Yeah. Do some people? I know you mentioned the apps, which which I was going to follow up and say, well, are there apps that, that they can use to check that? But is it helpful at all? Well, you're saying that it's not on labels of fruit, so people really can't keep track of how much they're taking in. They can't keep their own diary because they're not going to know that, correct?
Right. I will say that in the 4 or 5 years that I work in dialysis, I never used an app with any patient. Never had a patient using this type of app. And the reason why it's because most of my patients, they were elderly and they didn't feel as comfortable using, this technology. So it's more so kind of like doing a food recall and seeing what foods the patient eats more often. Because as a dietitian, I do like a deep dive tool, right? What are you eating? When are you eating it? How often are you eating it? Are you taking your medication? How are you taking your medication? Are you taking it too soon? Are you taking it too late? And as a dietitian, that's something that I will sit down with the patient with a lot of time and kind of like go through that food recall to see exactly what might be causing the high phosphorus.
Okay. So they
with
could
the
keep
app,
a food diary. But yeah, it looks like Rose is asking about it.
Yeah, that usually helps. I found it more helpful with elderly patients. I know the National Kidney Foundation does have an app. It's specific for renal disease. However, I have never played with it, so I'm not exactly sure of what it tracks and what functions they have in this app. But you might want to take a look at it and see how helpful it is for you. In terms of compliance, I will say making sure that you develop a habit of taking the pill. Like it becomes like second nature to take this medication. Okay.
And Rose, we can see if I do know there's an app that I had somebody telling me about that checks a lot of the different levels, and I'll see if we can find some that people would recommend. I will include them in a message when we send out the slides and the recording announcement. So we'll look into that to see if anyone can recommend any in addition to what Frances has already said. Looks like yes, another question there.
Yeah, so Yassi says, I take binders as well as Tums. Does it make a difference in taking Tums for vitamin D? That will depend on why do you take Tums and when you take your Tums. Tums, it's calcium carbonate, so this is like an easier and cheapest way, of having a binder. So if you take your Tums or the calcium carbonate with your meal, it's going to act as a binder. If you take the Tums in between your meals, because your Tums is to increase my vitamin D. I will say that it'll be better if you consult your doctor, and the reason why it's because some people can be sensitive to calcium. So if your calcium is within range and you are not taking Tums as a binder, you might be giving more calcium to your body than what it needs. And you can get a vitamin D supplement by itself. So if you're taking the Tums just to get vitamin D, it's better if you just take the vitamin D by itself, because the vitamin D helps with the absorption of calcium. Calcium doesn't help with the absorption of vitamin D. It's not how would you say that one affects the other, but it's not the other way around with the calcium, okay? Yeah, so if you're taking Tums in between meals, and this is why I say it, right? I had patients using sevelamer for binders, and they will take Tums for stomach, for reflux, or maybe indigestion. Sometimes that Tums that is that calcium that is in that Tums, it might raise your calcium levels, right? And I talk about the product, this calcium phosphorus product. So if you're giving extra calcium to your body that it doesn't need, it might elevate this product and increase the risk for calcification. So unless it's not prescribed by your doctor, I tend not to recommend taking calcium supplements.
Okay, that's good information, and I like the way of hearing how one helps the other, but not the other way around.
Yeah, it's not the other way around.
I hadn't heard that before. So yeah, that was good information. Thank you. It doesn't look like there are any other questions there. So I once again want to thank you, Frances, for your presentation today. I want to encourage everyone to complete the feedback form that will come up as the program ends, or when you get the slides and the recording, please fill it out. And we encourage you to join us next month on July 30th for our next patient webinar, and it will be on transplants. So we'll be talking about transplants, donors, and we'll have some a learning session as well from some of the patients who have had transplants. So please join us then, complete the feedback form, and thank you all for sharing some time with us this afternoon. And Frances, once again, thank you very much.
No, thank you. Thank you for the invitation. Thank you so much, okay? Have a nice one.
Okay, you too. And it looks like there's a number of thank yous in the chat
yeah,
box.
I'm reading. Yeah, I'm reading. Thank you so much, everybody. Thank you.
All right. Have great days, everybody. Stay safe. Bye-bye.
Bye.